Good morning, everyone, and welcome to today's webinar. My name is Sean Smith. I'm the Administrative Director for the Behavioral Health and Wellness Program. I am going to be handling the tech support for today's call. I'm also going to be kind of managing this for those of you who've been on these calls before, attended our webinars before. I'll be fulfilling that role. Today's topic is on the role of implicit bias in tobacco treatment for behavioral health populations. And we have our two presenters today, Mary Mancuso and Nicole Mueller, and I will let them go ahead and introduce themselves and go ahead and get started.
Hi, everyone. This is Mary Mancuso. I am the Clinical Program Associate at the Behavioral Health and Wellness Program.
And hello, everyone. My name is Nicole Mueller, and I'm a Community Liaison with the Behavioral Health and Wellness Program.
And so today in our webinar, the objectives of our webinar today are to address and discuss the concept of implicit bias in our society, how implicit bias factors relate to the behavioral health population, the impact of implicit bias on clients in tobacco cessation treatment, and strategies for increasing awareness and counteracting implicit bias for healthcare providers. So let's start with an overview of implicit bias. So what is implicit bias? Implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. So it's activated involuntarily without awareness or intentional control. It can be either positive or negative, and everyone is susceptible. So what's important to keep in mind is that implicit bias is characterized by its unconscious, automatic, and quick nature. So it essentially happens without us even realizing it's occurring. So let's take a little time to look at the actual terminology that we're using. So when we're talking about attitudes, we're talking about the evaluation of concepts. So persons, places, things, ideas that can be either positive or negative, and also can be either explicit or implicit. So for example, an explicit attitude are those that you consciously think about and admit. So you admit to yourself that I like math. Implicit attitudes are those that we may not even recognize we have or have control over. So maybe you say you like math, but you still have a negative association with it, such as doing homework late into the night and math problems at school. So you really do have a negative implicit attitude toward math. When we're talking about stereotypes, we're talking about the beliefs that we hold that most members of a group have a particular characteristic. So for example, women are nurturing, police officers all like donuts. Stereotypes can also be positive or negative, and they can also be explicit or implicit. So explicit stereotypes, again, are those that you consciously think about and admit. So for example, you might recognize that you have a stereotype that teenagers are impulsive. Implicit stereotypes are those on an unconscious level and are difficult to control. So for example, if you think, you may think that men and women are equally good at math, but in your mind, you might associate math with men more strongly than with women and not even necessarily be aware of it. So when it comes to biases, you might be aware of some that you have, including attitudes and beliefs about a person or a group of people. So as in our previous example, we're talking about teenagers. You might consciously believe and admit that you think teenagers are impulsive. It's explicit because it's in your conscious mind. Implicit biases arise in your unconscious mind and are greatly influenced by culture. So these may not even align with the beliefs you have about yourself or the values you hold. You might consider yourself to be accepting of all races and ethnicities, but your implicit biases may lead you to have a preference for one race or ethnicity over another. So individuals have been found to hold implicit biases despite the fact that they consider themselves to be egalitarian or being unbiased in general. So according to several researchers in the area of implicit bias, people often respond automatically, frequently, without awareness to others' race or ethnicity, activating stereotypical beliefs, emotional prejudices, and discriminatory tendencies. Prejudice and stereotypes do not have to be consciously endorsed to produce discrimination. So how do implicit biases arise? Where do they originate? They are formed as a result of mental associations that we amass over time due to direct and indirect messaging about groups of individuals and repeated exposure to groups of individuals being paired with specific associations that may or may not even reflect reality. So for example, groups of individuals such as Black men being paired with a specific characteristic over time, such as athleticism, leads us to and reinforces these automatic and unconscious associations that we assume are true even if they're not. So another example is associating women as a group with the characteristic of lacking mathematical ability. And there are various demographic characteristics that can trigger implicit bias. So some of these are age, maybe millennials or older adults trigger implicit bias, geography, people living in a certain region of the country, sex or gender, socioeconomic status, behavioral health diagnoses or presence of substance abuse can trigger implicit bias, race or ethnicity, sexual orientation, and weight. So these are characteristics that are studied in the literature, and then also there are characteristics that you can test yourself on to see whether you have implicit bias in these areas, and we'll talk about that at the end of the presentation.
So when we're talking about these unconscious biases, you might be wondering how this is measured. But researchers have been working on this now for a number of years, and they've identified a few different means that they can measure unconscious bias. So one of the more common methods is the assumption method. So the assumption method is used during randomized experiments that measure an effect across participant response to vignettes. So within these vignettes, often it's just one feature that differs, and it's testing bias against that feature. So these vignettes are often clinical, and they're used in many healthcare studies. And an example of the assumption method would be a relatively famous study on employment, where researchers sent out exact identical copies of resumes to a variety of different employers across sectors, and found that depending on the name that was provided, whether it was associated generally with individuals who are white or individuals who are Black, it differentiated the number of callbacks that those resumes received. And it was found that white names received 50% more callbacks, regardless of industry, occupation, or even level of experience. So the most common method to measure implicit bias is the implicit association test. So the implicit association test was introduced in 1998, and it measures response time when you're given associations, and that will determine bias. So really, it's measuring preference to various degrees. So this implicit association test is used in Project Implicit, which is a big project out of Harvard that is really driving a lot of the implicit bias studies in the US today. And you can actually take these tests online if you're interested. So they have a number of different studies on gender, religion, race, and we'll give you the link at the end of the presentation if you'd like to explore some of this yourself. So finally, we also have two other means that implicit bias are measured in studies, and they include the evaluative priming task, or EPT, and the affect misattribution procedure. So these are less commonly used methods, where the EPT measures or evaluates the speed at which participants label something as positive or negative after being exposed to a positive or negative image. And the affect misattribution procedure involves providing participants with bits of information. So information will be introduced, and then bias will be measured, and then additional information for the same situation will be provided, and then the reaction bias will be measured once again. So for example, there was a study where participants were told about a man that was breaking into a home, and it measured initial attitudes towards this person. And then they then gave participants additional information that the man was attempting to save a child during a fire, and then measured the difference in bias and reaction following that. So researchers have been working to identify the way that implicit bias operates in numerous sectors of society. So some of the predominant sectors have been the legal, employment, education, housing, and healthcare. So in the legal sector, researchers have really been looking at things like how implicit bias might impact a jury's verdict. In employment, you can look at the study that we mentioned previously about resumes and callbacks. Education, there's a lot that's been identified with regard to teacher implicit bias and how they react to student behavior, and then associated discipline. In housing, researchers have evaluated things like whether or not applications are accepted for particular individuals, and we're going to talk about healthcare extensively.
So when we're looking at implicit bias in healthcare, as early as 2002, the Institute of Medicine recognized that implicit bias was a factor that actually did contribute to disparities among different populations, health disparities among different populations. So researchers designed a model, a general model, outlining how healthcare provider implicit bias can contribute to health disparities via two paths: by unconsciously treating patients differently based on factors such as race, age, or social status. So if you look at the model, what we see in path A, we see that provider implicit bias may affect their judgments or decisions regarding patient care, which then lead to health disparities directly. So for example, provider implicit bias may result in shortened consultation times with certain patients, or decreased probability of referral, or impact decision to offer pain medication. Then if we look at path B, we see that provider implicit bias may negatively affect interpersonal communication between healthcare providers and patients and undermine trust in the relationship. So this in turn can impact patient perception of providers, such as perceiving discrimination, and then as a result, patient engagement and adhering to courses or plans of treatment may be impacted, which can then lead to disparities in health outcomes. So an example of this would be a provider using limited eye contact with a certain patient, and then the patient may resultingly perceive that the healthcare provider is discriminating against him or treating him differently, which then leads the patient not wanting to come to his medical appointments or follow the provider prescribed course of treatment. So then additionally, these two paths can interact. So for example, we might see a negative decision on the part of the provider, such as a shortened consultation time or decision to prescribe less or more pain medication, then impacting the communication and trust between the patient and provider. So we do see examples of implicit bias affecting quality of communication between healthcare providers and patients in the literature. One study found that Black patients perceived physicians with higher levels of implicit bias, which were measured by the implicit associations test, as being less warm and friendly. The patients felt less respected by the physician and even had less confidence in the physician during the clinical interaction. So in terms of the literature on implicit bias, recent systematic reviews have found evidence of implicit bias present in healthcare professionals, as well as a positive relationship between level of implicit bias and lower quality of care. And another recent systematic review, specifically focusing on race and ethnic bias, found that implicit bias was found across healthcare providers in varying specialties with different levels of experience and amount of training, and that implicit bias was significantly related to patient healthcare provider interactions, treatment decisions, treatment adherence, and patient health outcomes, all of which can potentially impact health disparities. And then furthermore, the actual environment of healthcare itself can contribute to implicit bias, because we know that highly stressful environments and being busy are two conditions which can make individuals more prone to making biased decisions. And then individuals who are working in healthcare settings already have a tremendous cognitive load. So that is they're already trying to keep a lot of information in their working memory and process it at the same time. And what research has found is that individuals who are already cognitively depleted or mentally tired have higher levels of racial bias compared to individuals in control groups. So if we're already asking healthcare providers to track all of these information that they're trying to do while they're providing patient care, but also monitor their levels of bias, including verbal or nonverbal communication in their overall interaction with patients, it's actually increasing their cognitive load and could contribute to omissions in care, such as failing to ask relevant questions or not noticing important information needed for accurate diagnoses. So to reiterate, many factors can lead to disparities in health outcomes, including racial or ethnic minorities trusting physicians less, patients having less trust in providers or even the healthcare system in general, which result from past associations with medical research, such as the famous Tuskegee syphilis study, providers offering different treatments based on race or social class of patients, communication between patients and providers, and even how patients are diagnosed. So for example, middle-aged women are less likely to receive a diagnosis of coronary heart disease, but more likely to receive a mental health diagnosis than their male counterparts.
So now we're going to shift into talking about the role of bias specifically within tobacco treatment. So in order to do this, we first wanted to look at examining explicit attitudes about tobacco, because these will actually work to shape stereotypes and ideas about tobacco use that will be then converted into implicit bias. So one of the primary explicit attitudes that needs to be examined is tobacco use as an individual choice. So tobacco use is commonly perceived as being an individual choice rather than the effect of a highly addictive substance. So this perception of tobacco use as an individual choice was actually something that was perpetuated by tobacco companies to mitigate public health concerns that pertained to tobacco use. So for example, you might have heard of the idea of smokers' rights, which emphasizes the idea of the right of the individual to choose to use tobacco. However, this perception of tobacco as individual choice has then led to tobacco use being seen as a voluntary act. So it's commonly interpreted now as poor and or antisocial behavior. So then this perception of tobacco use as individual choice has been shown to influence a variety of factors, and that includes the provider provision of care. So for example, it's the lack of patient motivation that's been cited as the primary barrier to tobacco cessation by physicians in the US. So moreover, it's been found that the majority of physicians believe that smokers do elect to continue smoking. So then these beliefs in turn impact the degree to which physicians are actively engaged in tobacco cessation with their patients. So as a result, it's the physicians with greater knowledge about tobacco and the effectiveness of tobacco cessation interventions, or the physicians that recognize tobacco use as an addiction rather than view it as an individual choice, who've been found to be more active in cessation activities. So then beyond just provider treatment, there's implications in policy, and in particular for insurance coverage. So this pervasive perception of tobacco as individual choice has also served as a barrier to policy that would otherwise address and encourage smoking cessation. So when you look at insurance policy, that's a good example. So tobacco cessation coverage isn't really costly, and in fact, it's been found to be cost effective. However, prior to the Affordable Care Act, most insurance plans, and that includes Medicaid, did not cover tobacco cessation medication, counseling, or treatment. So in turn, it seems like this is likely due more to the way that tobacco is associated with some sort of value judgment than about cost or some sort of business reason. So that might be similar to judgments embedded within obesity and substance abuse. So then importantly, these factors about the perception of tobacco coalesce, and it's to the detriment of tobacco users themselves. So in fact, studies have found that smokers are actually becoming increasingly marginalized in the United States. So these studies have shown that smokers are being pushed through the periphery of their social networks. And then when you think about it, it has broader implications. So it's also influenced other policy measures. So for example, some employment agencies and firms aren't hiring smokers. And then insurance companies are actually allowed to charge more for smokers. So some of this increasing marginalization may be related to the way that the groups that continue to have high prevalence rates are individuals with behavioral health conditions or low SES individuals, who are also groups that have been marginalized in the US today. But tobacco use is also an important factor to consider. So additionally, another facet of explicit bias in regard to tobacco use that's important to consider is tobacco in the behavioral health community. So traditionally speaking, tobacco cessation wasn't viewed as a priority within the behavioral health community. So there's common myths that were actually perpetuated again by the tobacco industry that tobacco use was actually providing treatment for individuals with behavioral health conditions, so that it offered symptom management, self-medication, and fulfillment. So it's important to be thinking, even as we begin to dispel these myths and these explicit biases, how this might implicitly be impacting provider treatment and treatment goals.
So when looking at the behavioral health population, what this graph is showing is the change in smoking rates in the general population from 1955 to 2013, which are indicated by the green line for men and the red line for women. But what we're also seeing in this graph are the tobacco use prevalence rates by mental health and substance use diagnosis. And we see the ranges from the available studies. So for example, people with PTSD smoke at rates from anywhere from 45 to 60%. So what we know is that individuals with behavioral health conditions smoke at rates 2 to 3 times higher than the general population. They represent almost half of the US tobacco market at 44%. And while about a quarter of the general population, or 25%, has either a mental illness, or substance use disorder, or both, this group as a whole consumes 40% of all the cigarettes smoked. So this is a disproportionate amount of all the cigarettes smoked compared to the general population. And as we've touched on before, with the release of the documents from the Master Settlement Agreement, we know that the tobacco companies actually paid for research that supported the idea that individuals with certain behavioral health conditions, such as schizophrenia, were less susceptible to the harms of tobacco use. However, this is not the case. Individuals with behavioral health conditions who use tobacco have more psychiatric symptoms, have increased hospitalizations, require higher dosages of medications, and thus have more side effects from these medications, and actually die 25 years earlier than the general population, not from their behavioral health condition, but from diseases related to tobacco use, such as heart disease, cancer, chronic respiratory disease. So people with behavioral health conditions are just as likely to want to quit smoking as people without behavioral health conditions. And in fact, 75% of these individuals want to quit, and 65% of them have tried to quit in the last year. They want information about smoking cessation resources. And these individuals can and do quit smoking. While their quit rates are lower than among the general population, they are not substantially lower.
All right, so now we're going to talk about implicit bias, and tobacco users. So we've talked a lot about providers and how provider implicit bias can impact care. But unlike the examples we've discussed previously, it's interesting to note that with tobacco, individuals and tobacco users themselves also have some sort of implicit bias towards tobacco use. So tobacco users can either have a positive or a negative implicit attitude towards tobacco. So having a positive implicit attitude reflects an unconscious favorable view of tobacco use. And then having a negative implicit attitude reflects an unconscious unfavorable view of tobacco use. So implicit attitudes are malleable, and they can change based on a variety of factors. So pattern activation actually takes into account the role of a particular environment or stimuli within implicit attitude shifts. So pattern activation is particularly important to consider in regard to smokers. So this is due to the fact that smokers experience both negative and positive effects of tobacco use. And in turn, they've been found to have both negative and positive implicit bias towards tobacco use. And it can change. So specifically, tobacco cravings and dependence have been found to be linked with these shifts in implicit attitudes in smokers. So smokers' implicit attitudes about tobacco are generally more negative immediately following tobacco use. They're more positive following periods of abstinence or when they're experiencing withdrawal, and then in turn, cravings can increase positive associations for smokers with tobacco. And it might seem like since both smokers and non-smokers have been found to hold negative implicit attitudes towards smoking, that these attitudes may not have much impact on smoking behavior and cessation or quit attempts. But that's not actually the case. The majority of the literature doesn't support that. And studies that have found that have had different reasons, like smokers being asked to self-identify, where individuals who considered themselves to be social smokers may not have identified as smokers, and it could have skewed the results in some way. But the majority of the literature does show that implicit attitudes have an impact on smoking behaviors. So for example, implicit attitudes have been found to be predictive of smoking onset in non-smoking adolescents. And then this is particularly interesting knowing that those implicit attitudes were also found to be transferred by their parents. So additionally, implicit attitudes about tobacco are associated with quit attempts, cessation, relapse, and abstinence. So negative implicit attitudes, so again, as a reminder, that's viewing tobacco implicitly as being something that's unfavorable, are an important factor when smokers elect to quit. So during one tobacco cessation intervention, it was found that negative implicit attitudes at the midpoint of the intervention were significantly related to quit attempts. And then the same study found that negative implicit attitudes following the intervention were significantly related to smoking cessation. And then similarly, other studies have found that these negative implicit attitudes are also predictive of 8-week abstinence. So when we're thinking about the way that we address tobacco treatment, we often talk about addressing physical symptoms, so the actual physical addiction to nicotine and withdrawal, and the behavioral symptoms, so that habit of using tobacco. But what this research on implicit bias seems to indicate is that in the behavioral aspect of tobacco dependence, we need to address both the implicit and the explicit nature of tobacco addiction and those attitudes that are associated. So the interventions that include measures that will address both implicit and explicit attitudes are known as dual process models. So there's a number of different intervention recommendations for patients who are tobacco users, and those address both the explicit attitudes and the implicit attitudes towards tobacco use. And it's essential that both are addressed. So first, explicit bias can be addressed through things like education or media campaigns, where you're actually providing information about tobacco use to patients. But additionally, it can be addressed through motivational interventions. So for example, motivational interviewing or cognitive behavioral therapy, where you're actively increasing the motivation of clients to quit. In comparison, implicit attitudes can be addressed by creating new associations with tobacco, retraining attention, and making controlled processes automatic. So what does that mean, and what tools can be used? So the literature has indicated that one tool that can be used is approach avoidance practice. So approach avoidance practice is a strategy that's used to reduce positive implicit bias, and in this case, with regard to tobacco use. So throughout the activity, clients physically pull or push pictures of target objects in order to affect or habituate their implicit attitudes and automatic processes with regard to these objects. So in the case of smoking, it would be cigarettes or other types of paraphernalia that are tobacco related. And then approach avoidance practice was found to help increase negative implicit attitudes in tobacco users. So it's important to note that this effect was found to be greatest in individuals with less education and not particularly effective for individuals with a college education or higher. But knowing that the majority of smokers today do have a low education level, it seems that this method might actually be fairly effective with many clients. And then researchers also believe that one session of approach avoidance practice isn't enough to actually address implicit bias in tobacco users. So you have to do more than one session. And additionally, it should be done in conjunction with a motivational component, like MI or CBT, that will express or address the explicit attitude as well. And then one final approach might be designing a quit plan. And while a quit plan might seem like something that would also be part of addressing explicit attitudes, it actually can be used to reduce an individual's reliance on automatic processes. So instead of running on autopilot, your client will have a different way to handle cravings and that sort of thing. So this would then mitigate the role of implicit bias within continued tobacco use. So it's important to work with your patients to help them to create an appropriate and tailored quit plan that will help them to address potential positive implicit bias towards tobacco use. So now we're going to return to maybe more familiar territory and talk about implicit bias in providers. So there have been a number of studies that have been done that have examined different aspects of patient identity and how they might impact provider care in regard to tobacco cessation. So one aspect that was examined was patient health, and it's been found that physicians are more likely to offer cessation information to patients who are sicker. And it's important to remember with that all patients benefit from smoking cessation, and that's regardless of health status, age, or any other factor. So patient education level has also been examined. And physicians have been found to be less likely to advise low education or minority patients to quit smoking. And that's particularly important knowing that the majority of individuals who continue to smoke today do have a low education level. And then in regard to patient race, it was found that physicians in the US in particular are more likely to ask Black patients about their tobacco use. And this is in comparison with the UK. But what's interesting is that these physicians, once asking about tobacco use, are far less likely than their counterparts in the UK to then offer cessation advice or assistance. So another factor that's been looked at is patient gender. And there's been some contradictory findings here, but overall it seems that providers are more likely to initiate an opportunistic discussion on smoking with a male smoker. However, in some studies, it's been found that more women actually recall being advised to quit by a doctor. And this could be for a number of reasons, one being recall bias, but another more important might be that women are more likely to actually see medical providers and to see them more frequently. So provider tobacco use is another factor to consider. So it seems that current smokers are actually less likely to establish patient smoking status and to provide quit advice or assistance to their patients. But in comparison, providers who themselves have quit are more likely to offer that assistance. And then finally, patient insurance status is something to consider. So providers that were familiar with their patients' insurance coverage were more likely to provide cessation assistance. And this has changed slightly with the ACA and expanded coverage for tobacco cessation activities. But when you consider the fact that a number of the populations that have high prevalence rates in regard to smoking, like the homeless population, may not have insurance coverage. So that's something to keep in mind.
So let's look at some strategies to reduce implicit bias for healthcare providers. Much of the research that's been done in this area are looking at healthcare providers, including medical students, nurses, physicians, and even healthcare organizations themselves. But one study that was conducted that did not involve healthcare providers as participants examined the effectiveness of using multiple strategies to reduce implicit bias. And it took place over a 12-week time period. So not only did the researchers find a reduction in implicit bias for the study participants, but this reduction endured post-study period. So the intervention involved two components, education and skill building. The education component included information about the development of implicit bias and its automatic nature, the prevalence of race bias in our society, and consequences of perpetuating racial discrimination, and then resulting outcomes in health, employment, and daily interactions due to such biases. So as implicit bias is automatic, we need to train our brains to engage in automatic processes which counter potential implicit biases. So this intervention done in this study also included skill building elements as well, including stereotype replacement, counter-stereotypic imaging, individualizing, perspective taking, and contact. And we'll discuss each one of those. So stereotype replacement involves recognizing stereotypical responses within yourself or in society, labeling them as stereotypic, and then reflecting on that response. So for example, Jewish people are good with money, or gay men dress well, or Black men are good athletes. These are all stereotypes that we have as individuals or as society. So you would label that as a stereotype and then reflect on why you had that response. So the counter-stereotypic imaging is where we imagine examples of out-of-group members who counter popularly held stereotypes and who are positive and accessible. So an example of this would be Barack Obama. Individualizing is when we view others according to their personal rather than stereotypic characteristics. So instead of seeing Tom as a man with diabetes, we would have a conversation with him and get to know him as an individual person. Perspective taking involves adopting the perspective in the first person of a member of a stigmatized group. So empathizing with someone and actually trying to put yourself in their shoes. So thinking of what Rachel's life is actually like as a single mom with low education level. And then finally, having contact with people who are outside of your group. So simply spending more time with people who are in a different ethnicity or race or age, sexual orientation, or even socioeconomic group than yourself. So in terms of healthcare settings, what we're really seeing is that it's important to start early in the career of healthcare providers, so that strategies to reduce implicit bias are embedded in the medical school curriculum and can really become part of their just overall approach to patients. So we really want to encourage our healthcare providers to consistently engage in patient care with these egalitarian goals in mind and really approach every encounter with patients who are members of underprivileged or stereotyped social groups as an opportunity to reinforce and act out these commitments to egalitarian values. So these egalitarian goals are treated like a habit that can be reinforced with repeated practice and effort, which will help these values become unconsciously accessible and automatic, and really part of a personal transformation process and consistent commitment to egalitarian values. Other recommendations to include in the medical school curriculum are increasing self-awareness, such as self-reflection, taking implicit bias tests, forming new positive associations with individuals in an inclusive learning environment, engaging in positive interactions with minority groups, which will also increase cultural competency, developing and increasing empathy skills such as perspective taking, and really habituate egalitarian values, make it a habit. So in terms of healthcare organizations, researchers are finding that positive intergroup contact correlates with reduction in implicit bias in these healthcare settings, and they're really calling for a commitment to the norm of treating all patients equally. But another thing to really address in the busy, stressful environment of healthcare is that we really want to reduce the cognitive load for healthcare professionals. So training them not to rely on automatic processes such as stereotypes, as we've discussed, and then also really having standardized processes in place that can help reduce the need for decision making and possible introduction of involvement of implicit bias. For example, having a prompt in the electronic health record to ask every patient about tobacco use, and then HR electronic health record triggering a set of referrals for tobacco cessation services if a patient or client does use tobacco. So in closing, we would really encourage you to learn more about your own possible areas of implicit bias. And this is a link to Harvard's Project Implicit, which has a variety of implicit association tests examining potential biases in such areas as gender, age, disability, race, and religion. And we do encourage you to take these tests, as the results might surprise you. And now we will open up the line for questions.
Okay, and just to let everyone know, if you called in on a phone, you can press *6 to unmute yourselves. Otherwise, if you're using Zoom on your computer, you should be able to unmute yourselves manually there. Just in case you run into any issues not being able to do that, we also have the chat functionality that you can type questions in from your computer directly.
We'll just put up the Project Implicit website again, just in case just to give you all a chance to write that link down. But you can also search for it in Google. It'll come right up if you're interested.
And then we have a question about whether the PowerPoint will be sent out, and we will send out the slide deck, I believe.
I think we can send out, we can also send out the references if anybody is interested.
My name is Cassandra. I'm from the Brattleboro Area Prevention Coalition. So we work with promoting our cessation program in the state. So I'm not a medical provider, but I think it's just in general. I caught the second half of this. I'm sharing this time with my colleague. So you might have already referred to this, but have they found to have certain messaging resonate with particular populations? So, you know, right now we're like working with like low SES population and our queer youth, and like, is there different messaging that seems to resonate more with different populations, or is there a resource for finding out that?
With regard to tobacco cessation, is that what you're saying?
Yeah. I mean, like for example, you know, is saving money really resonating? You know, if you say, hey, you'll save, you know, $300 a month if you quit smoking, is that really, you know, from a middle class point of view, that might be like, wow, that's a lot of money. Of course, it would be all as well for low SES, but is that a motivating factor for them to want to quit? Like, is there anything around that?
Yeah, I mean, we talk about all the time, really, well, first of all, it's always important to tailor your treatment plan to the specific individual, and that's where culture comes into play and all of these other demographic factors. But yes, I mean, we talk with our clients all the time about just anything that is of value to that individual being a motivator for successfully quitting tobacco. So if money is a factor for them, because it does certainly add up over time, then you can focus on the financial piece of it and sort of get your clients to recognize how much they're actually spending in a week on cigarettes or tobacco products, and then thinking about what else they could spend the money on. That we found that to be really helpful. That's more of an explicit factor, kind of talking about something directly with clients that's really going on. But that certainly money is always operating, I would say, Does that answer your question? And you said you also work with queer youth?
Yes. Yeah. Or just,
Mm-hmm.
yeah, that
So,
population.
yeah, and so in that population, we do find smoking rates higher than the general population, simply because for many reasons, being a minority status, having a minority status is more stressful, and so that can impact just the overall stress of being of having that demographic. But then, especially with younger people, tailoring interventions that are, they like using technology, something that's free, that's not very costly, something that involves social peer group, something like that has been shown to be effective. So we do recommend tailoring interventions depending on a number of demographic factors, including age or social group, something like that. So does that answer your question?
Yes, and I'll wait until there's other questions. I have one more, but I want to make sure there's time for other people. That's unrelated to that one. But thank you so much for the answers for that.
Okay, thank you. So we have a question from Claire LaFrance. She says, can you say more about perspective taking exercises? So Claire, what we're talking about here is really, like I said, putting yourself in the shoes of someone else. So say, just so we're not operating with these implicit biases, so that you're actually putting yourself in the experience of someone else. Like, what is it like to be a minority? Or a refugee, or someone who just came over to this country and they're struggling to find a job or find a safe place to live or take care of their family. Just taking some time to really reflect on that and what it's like, and also sort of what it might be like to be in a position that is where people might be stereotyping you. You're not known as an individual, you're known as a stereotype. And so getting people to really take some time to reflect on what that's like. None of us want to be seen as a stereotype, depending on, whatever your demographics are. We all want to be seen as individuals. So I think really encouraging your clients or healthcare providers to really take some time to think about what it's like to be in the perspective or have the perspective of the individual.
And I think as far as a big picture goes, a lot of it comes down to slowing down the cognitive process. Mm-hmm. So the idea of mindfulness and making sure you're actively making decisions. So perspective taking is slowing down that decision that you're making, or that judgment call you're making about an individual that you're working with. So the types of practice that you can do may not necessarily explicitly be perspective taking, but how can you slow down cognition so you're not relying on automatic processes and using and deploying things like stereotypes to help you make decisions in high stress situations.
Mm-hmm. And we have another question from Ginger Cloud. Can you give more of an example of what a session on the approach avoidance practice might look like?
So I actually haven't seen it in practice. I've only read about it, but it actually seems to be fairly simple. So it's just working with individuals to habituate associations. So it sounds as though it's literally just taking images of target objects. So in this case, we're talking about smoking, but it's also done in substance abuse, I think more generally. So it might be alcohol or some other substance. And you can take those pictures and you practice pushing away the things that are negative. And I'm sure you have images that are positive associations, and you work at pulling those towards you. So those are things that you want and you desire. And so it's forming those automatic responses to particular images and objects. So does that answer your question a bit further? Mm-hmm.
And then again from Ginger, we have, is there a summary of potential implicit bias actions that might happen? And it sounds like you're working in a medical setting where it might be helpful to send out a summary of points to providers. I think that the good thing is that a lot of the research that's being conducted is in healthcare settings and with medical students. So there are a number of studies where the researchers are looking at what's effective with healthcare providers in reducing implicit bias, and then also really calling for changes in the medical curriculum itself, medical school curriculum. In terms of a summary of actions.
So there's literature reviews that have come out that cover healthcare in particular, but I don't know of something that's like a quick fact sheet, like a did you know? I know that the Obama administration actually published some information on implicit bias that was a fairly good summary, but I don't think it was healthcare specific. And I'm sure that there are resources out there. We can look and see what we can find.
Yeah, and I think a lot of it's not just healthcare, because as Nicole mentioned at the beginning of the presentation, implicit bias really factors into many areas of our society. And so we're talking about health, and we're talking about the legal system and education. So it's really impacting many areas of society. And so there are some reports that have been recently compiled and written that address implicit bias on a larger scale in terms of our society. So we do have access to some of that information, and we can put it on a resource page. And this is, implicit bias is a relatively young field of study in the literature, and so I think we're going to see more work being done on it. It's certainly come up in national conversations recently, and so I think it's starting to really take hold, and people are starting to look at it. So hopefully we'll start seeing some of those resource sheets that are sort of general information and sort of tips that can help with this. But I think one of the very important places to start is really just awareness and recognizing how much implicit bias impacts us on a daily basis.
That I don't know.
So we got another question from Ginger about the potential new healthcare American Health Act might impact NRT being covered by insurance companies. I think that I'm not as familiar with the new legislation, but it might not even pass. So
yes, so it's been proposed by Congress. It hasn't passed the Senate, and the Senate may actually write a different bill. So that I'm not sure. We can look into it, but it's not law of the land yet. So I think more information is to come.
But it is really nice to know that at least with the Affordable Care Act, they started recognizing that tobacco was a significant issue, and they're providing insurance coverage to help support it. So I think we're starting to see shifts in the way that society is looking at tobacco. In the new DSM, the DSM-5, the most recent DSM, tobacco is actually listed in the substance use section of the DSM. And so before, it never was in there. So you saw things such as other drugs, such as alcohol dependence and addiction, or cocaine or methamphetamines, but tobacco was never listed. And so now it is listed in the DSM-5. You can code for it and you can bill for it. So we are starting to see the differences in the way that tobacco is treated as an addiction, not just as a personal right, like Nicole was talking about, and seeing services and insurance for it. So hopefully that will continue as a trend in our society and in our insurance industry.
This is Cassandra Holloway again, and again, you may have said this already, but I know that one of the pushbacks that we get sometimes from medical providers and social service providers is that these people are, some people are already under a lot of stress, as we've talked about, and they don't want to add additional stress by, suggesting cessation, because it's kind of like, when everything else is happening, it's not necessarily looked at as a priority as far as, that makes sense. It's kind of like, it's almost like to me, sometimes it can be an assumption that we put on to the person, that, oh, their life's so special, they can't handle this. But I also feel like that's something that I'm constantly not constantly, but continually hitting with some social service and medical providers when I bring this topic up.
Mm-hmm. And I think that's exactly what we're talking about with this implicit bias, that many healthcare providers just sort of in the culture of behavioral health or medical settings, they just sort of have a very sort of ingrained understanding that, yes, this is a way of coping that this client or this patient has. I don't want to take it away from them. This is all they have, or, it's going to be too much. It's going to be too stressful to take away their smoking, as well as trying to get them housing or trying to get them a job, or, address other maybe more what they consider to be more pressing physical issues. But what we know is that people who do address tobacco, often, again, people who are with behavioral health conditions are dying not because of their behavioral health condition, but because many people are dying not because of their behavioral health condition, but because of diseases related to tobacco use. And so it's really important to address that. And also, we know that people who are struggling with other types of addictions like drugs or alcohol, tobacco is a way of tobacco is a coping strategy for maybe things like stress that might be going on in their life. And by having the tobacco as a coping strategy, they're not addressing the underlying issues of why they're maybe needing to get more effective coping strategies, or needing to develop communication skills so they can set healthy boundaries, or take, self-care skills that they need to really address. And the tobacco is sort of covering that up so that they're not addressing it. And then also we know from the literature that when you do address tobacco use at the same time as other addictions, you're more successful and you have a higher success rate and less relapse.
I think it's also important to note that it's an assumption on part of providers. So what we do know as well is that the majority of smokers are interested in quitting. Whether or not they're ready to quit on a personal level is maybe a different story, but they are interested in quitting. So it's up to providers to continue to ask that question and assess their readiness to quit and provide them with the tools and resources that they need. And it's not necessarily contingent upon whether or not they're stressed or overwhelmed, or if the provider doesn't think they can handle that. That's a decision for the client. And I think we need to make sure that we're providing them with those resources, especially if they're coming from a population where they might not have regular access to cessation assistance, medication, counseling, or even the advice.
And that's exactly what we're talking about with the implicit. I mean, reducing that cognitive load so that the decision doesn't come from the healthcare provider about offering cessation resources, but it's really just asked every time. And so then the decision comes from the client when they're ready, when they're when it's appropriate for them in their life to try to work on tobacco cessation. Did we answer your question?
Yes, definitely. Thank you.
Okay, those are great. We love getting all these questions. It's excellent.
So we have just 1 minute more. Is there a last question that we can answer for anyone?
And again, we can send out the references for this presentation as well as the slides to everyone on the webinar. All right, well, thanks so much, everyone, for joining us. If there's no other questions, well, we really appreciate this opportunity to give this presentation to you, and we really appreciate all the work that you're doing with clients and behavioral health settings to hopefully address tobacco. Thanks, everyone.
Thank you.
Bye-bye.